welcome to our last session of the Private Pregnancy Show, and we're ending with a blast with our esteemed panel here. And I'd like to welcome Sarah Denning, midwife and one of the founders of the birth team.
Hi.
And Richard Sheridan, Dr. Richard Sheridan, who's also consultant obstetrician, gynecologist, and also founder of the birth team. And the rest of our speakers we've spoken to, we've got, I'm not going to go through you all. I think you should introduce yourselves. If we start with you, Dominic.
Is it working? Yes. So we are the Bloom team from Bloom at 58, Angelique Panagos, nutritionist, Bryn Fur, osteopath, and myself, Dominique Antiglio, a sophrologist.
And if we move on to Jenny Smith.
Hello, I'm Jenny Smith. I'm a midwife, does caseload private midwifery, and also shares with the obstetricians at Queen Charlotte's Hospital for Imperial College. Thank you.
And down to Alex.
I'm Alex Iskander. I'm a consultant gynecologist at the Gynae Centre in central London.
I'm Gorgi, director and the fertility specialist at the Fertility and Gynecology Academy, Wimpole Street, London.
Thank you. So we've got a great panel here, so if you have any questions at all, please feel free to ask. And Sarah is going to moderate the session and ask questions to our team. And if I just might ask as well, because we have 45 minutes, so I know we've got lots of information to give out, but if you could just answer maybe one question and then move on to give somebody else an opportunity to answer the question as well. Thank you.
Okay.
Okay, Sarah.
Okay, so what we're talking about today is recent research carried out by the PP UK show, Private Pregnancy, revealed that British women believe that 44 is too old and should be the cut-off point when it comes to having a baby. Can I ask all of you individually for your thoughts on this, and please give one reason for your answer? If you'd like to start with that. Alan. So.
Myself? So that was 44 is the cutoff.
Yes.
I'd like to think that we're all biochemically individual, and I'd say that putting a number on it to that extent, I don't believe there should be a cutoff. Personally, I believe if you are fertile and you're able to fall pregnant, and we're talking naturally. I just need to understand the question: is this naturally or assisted?
We're just saying either that 44
Either.
is too old.
I think if you have this immense passion to be a mum, then should we be taking that away from anyone that's able to have baby?
Okay, lovely, thank you. Alan, what are your thoughts?
I don't think we have to put a cutoff age for who should be allowed to be a mum or not. We know, unfortunately, from the biological clock that the ovaries by the age of 44, the reserve is quite low and achieving pregnancy is difficult naturally. But biological alternative options, like including egg donation, should allow women at that age and beyond to be able to conceive. And we all have different circumstances. We have different backgrounds in life. Some people miss the train for one reason or another. I don't think we should tell them, no, you don't deserve to be a mom, so long as physically and medically their body is capable of accommodating a pregnancy. And actually, the receptivity of the uterus can be as good up to the age of about 54.
That's interesting.
I'm not promoting that they leave pregnant at the age of 54, but 44 in the current age when people live into their 80s, even if she had a child at 44 or 45, there's probably another 30 years to see that child growing up. So I don't think cutoff age is the right thing to do. So. And we have different circumstances. We do different things in life.
Okay, thank you. That's a lovely answer. Amber, what do you feel?
I think that physiology does come into it, but I think in this day and age, our 40s are no longer as they once were. People are taking better care of themselves and more conscientious about health and diet. And although there are stresses in life, if you have been maintaining yourself in a certain way, there's some 44-year-olds that would give a 30-year-old a run around the block. So I don't think we need to actually put a definitive on it. I think each case is individual.
Yeah. Alex, how do you feel?
Yes, I like to differ really with my previous speakers. So although it is possible to get pregnant at the age of 44, but I think we have to be realistic. The number of eggs decline, the quality of the eggs decline. Women also start to have medical problems in terms of hypertension and diabetes, and these can cause problem for the women to be pregnant at this age, and for the pregnancy itself to be complicated if they have diabetes and hypertension. So if it is possible, if you can plan your life, I think it's better not to leave it until 44. But if you do at 44, make sure you look after your health, no hypertension, exercise, stop smoking. There are ways to get you pregnant. The chances will be less, and you may require artificial ways of getting pregnant, like egg donations, etc.
So you're saying preconception care is very important?
Preconception and look after your health, because hypertension and diabetes are common after the age of 40.
Oh, okay. Thank you. Jenny?
I think that it's quite interesting when you're thinking of a first pregnancy or a subsequent one. And certainly, I think the health of the mother, I've obviously seen some in my time of people beyond 44 going up almost to 52, where people actually can get considerably unwell and need quite a lot of inpatient admission with the disorders that you've so correctly sort of mentioned. So I think it's a balance of informed choice for the mother, and of course we're all different walks of life, and maybe somebody hasn't met someone till much later, and of course we want to make sure their journey is as safe as possible. So I think, again, it's very individualised, but I think you have to spell out some of the risks as well. I've certainly delivered a number of women who have had pregnancies before of normal birth. And I think sometimes once they've sort of had a baby before, the passageways have all had a vaginal birth before, I think with some of them it is somewhat easier, because although they sometimes do go to 40 weeks, but by the nice guidance that we all tend to go by, they tend to have their baby a little bit earlier by inductions, often very easily, if they've had a baby before. So I think very individualised, but very balanced sort of approach with anyone who wants to go on that far. And obviously egg donation is high in some areas in London. I've certainly seen that a number of times. But it's good if the mother's body is strong and healthy before that all starts as well.
Yeah.
Thank you.
Similar thing.
So I think it's a question of choice for the woman, freedom of choice. I think it's important, and whatever she chooses, I think it's so important that she has a team around her, that she finds the right people to help her medically, of course, midwife, but also, looking after herself in all the, like nutrition, and as Amberine said before, mechanically, how she, her whole health and lifestyle plays a big role as well. So I think it's a whole. It's looking at the person as a whole.
Okay, thank you, Richard.
I'm reminded of that game where you're last in the line and everybody's had a go before you and you struggle to find something to say. I'm going to look at it from the obstetric perspective. The clever doctors at the other end of the line will make a lot of these 40-plus-year-old ladies pregnant because the natural conception rate is low at that age. And I see lots of patients in their 20s that I don't think should get pregnant or should be pregnant. And if you're overweight and you smoke and you drink and you're 20, there's far more reason for you not to get pregnant than a fit woman in her 40s. Fit women in their 40s, once they're pregnant, and getting pregnant is a different ballgame, often do very, very well. There's evidence that the placenta may not function as well after 40 weeks. But I've had experience of lots of women in their 40s who, once they are pregnant, behave normally and very well. The problem is getting pregnant, and sometimes you need to be aware of when your biological clock is ticking.
Thank you very much. So leading on from that, I'd like to ask you too, how far should medical intervention and assisted conception go when it comes to helping women who wish to preserve their fertility or delay having children? When do you think too far is too? Amin, can I ask you that?
So are you asking how far we can go? What
how
age?
far should we go?
I think up to the age of 50 is not unreasonable in the current age. As I said, we live longer now, we live healthier, so that's reasonable. Having said that, I don't mind giving treatment to few women beyond 50, but this based on their circumstances, and always we have a clinic meeting to look at the circumstances and decide that every member of the team is comfortable. Having said that, at any meeting, I tell the staff that whom do we think we are to judge people?
Yes, it
we
comes
are
back to
looking
the same
at
question.
the best interest of the mother and the baby, but we're not judging people. We're not deciding who can get pregnant and who cannot get pregnant. But we're doing our duty to make sure we looked enough into the welfare of the family, the mother, and the potential child.
Yes, thank you. That's a good answer. Alex, do you have any other?
Yes, but is there a written law to say that there is an upper limit? No. So it's an unwritten agreement.
It's sort of unwritten agreement that each clinic will submit in their SOPs to the HFEA what age limit they'd like to choose. The HFEA will look into this particular issue ethically rather than law. There is no law, there is no age limit by law. But if you submit something and you do something different, you have to answer. So once you say, well, my age limit is 50 because we feel as a team that what we do, you got to abide unless you have good reason to go beyond your SOPs. In our SOPs, we put the age of 50, but we put a paragraph that in very special circumstances, we can look into patients beyond that age and based on their circumstances and the ethics meeting in the clinic.
So you would consider somebody at 60 and plus?
In very special cases, yes.
In very special cases, yes.
Okay, thank you. Alex, what are the most common problems that you see women coming to you for? What are the most common issues?
In gynecological practice, abnormal bleeding really is fairly common. And then with fertility issues after the age, for delayed conception after the age of 35, I think comes next to after abnormal bleeding.
How many women over the age of 40 do you get coming to you? Do you find it's more now, or has it increased in the last 10, 15 years with fertility
problems,
issues?
Yes. There are many, actually. I think Amin would probably be in a better position because he looks after the fertility aspect.
I think there are two groups of people come out after the age of 40. Some women who were too busy with life to consider having a family, and they were under the wrong impression that so long as they have the period, pregnancy shouldn't be a problem. And actually they're shocked when they come after the age of 40. We tell them that your ovarian reserve is quite low, the chance is that %, and they, why? I'm still having my periods. So that's one group of them.
Yes.
But the other group who have been trying, unfortunately, for a number of years, and we have quite a few of them, who had been through IVF several times and not successful either because they have other medical issues like immune issues or because their ovarian reserve is very low and the egg quality is not good.
Okay.
But these are the two main groups. But I just want to add that in older age group, like above 45, as Mr. Skander mentioned, there is a potential problem with medical issues, but we screen the patients. We ask them to have mammogram, ECG, a report from the GP, including the blood pressure and the blood sugar, and make sure that they physically fit to accommodate a pregnancy or to support a pregnancy. So they can have it late in life. It's not necessarily that the best thing to do, but we need to make sure that they are healthy enough.
Great. Okay, thank you. I think we could probably all agree from that women as they're approaching pregnancy in their 40s, 40 plus, are actually very much more aware of their health than someone who is 20 or even 30 maybe. So moving on now, if we suppose that our ladies have got actually pregnant. Jenny, I'm going to move to you and ask you about what are your top 3 tips for mums to manage pain when they're going through labour, if we move on to labour?
Right.
Would you say the 3 most important things?
Yes. Well, I mean, a bit like some of the other speakers today, I think it's to get yourself sort of practice to surrender to the labour. And I work on my sort of practice with the swirl and the depth of the top of the contractions in the middle of the swirl, and then you swirl out. And then each contraction comes, there's a gap, rest and be thankful before the next one, and you think that contraction gone, the next one to near meeting your baby. So it sort of evolves, and then around that to sort of keep mobile where you can, have snuggly bits to keep you feeling comforted, keep your environment at a low sort of level of delights, and you can do it 1,000,000 times through the labour. Come on, you're doing so well, you can go through, and have everyone sort of focusing on the mother to try and sort of achieve that throughout the time.
And what do you think are the best things that their partners or birth partners can do to help?
Well, I think sort of really what they want. I mean, it's sometimes some men are sort of slightly in the corner, and that's where the mother wants them, like, don't move from there, I need you, but I don't want you to touch me. And we have to sort of sometimes think, that's a little strange, but that's how she needs. She doesn't want him going, but she doesn't want him touching her in any way. Other people are, you know, very, very dancing in labour together almost the whole way, and they almost know when she needs a drink of water, when she needs to spray, when she needs to sort of, you know. And I think we also plan quite a lot that sometimes in the pregnancy, what they think they might want in labour, it might not be that at all. Don't do this. I thought I wanted, but don't get me, you know. And it's so that people, I think, are very much during the contraction. You can't really get distracted by things. It's almost like you go under the jumper, and then you come back again. And it's to sort of evolve that with whoever's around, giving them their needs, you know.
So really, it's preparation is the important thing, isn't it?
Preparation is, but I think
we're
also
talking about how things might go.
Yeah, and being flexible in labour, because it might not be how they feel at the time, how they planned it.
Thank you. I'd like to hear really from any mother who's had a baby before. Is that effective to manage labour pain? Anybody had?
I've had 3.
Yeah.
And I have to say, my top tip would be the breath, because I was actually, there's so much you can do during pregnancy, and I did antenatal yoga quite late on, and it was less to do, for me anyways, it was less to do about the postures, but it was on how to control my breath and how to actually delve into the breath. So it was meditative without meaning to be, but the pain control on that was incredible, and I found that I had a very difficult first labor. It was 12 hours and unremitting in terms of pain. I had gas and air, but it was the breath that actually saw me through it. And the second and third, you know, I know I'm an exception to it, but I had 2 water births and no pain relief. And it was the breath that really coached me through regulating my heart rate, being oxygenated, and maybe I was lucky. But I'd like to think it was the breath.
Dominique, on that, dynamic relaxation. Sorry, beg your pardon, getting back to it. How does that help pregnant women?
So I think, you know, going back to how you can prepare for birth, I think feeling in control is a big part of reducing the stress, whether you learn some dynamic relaxation technique like sophrology or hypnobirthing. I think at the end it's preparing to feel that you have something to do on the day, and
yes.
that plays a big part of feeling empowered, and that you're going to decide how you're gonna go about this experience, rather than being either taken by it or forced in it, or, you know, I think that plays a big role to be able to.
So having knowledge as well as having something positive to do.
Exactly, and I think these days we are living in a fast-paced life where women don't have time to connect with their bodies. They're running from work to home, looking after the kids, and we take very little time to actually breathe and connect to what we feel. We are a lot in the mind, and I think a successful birth is also a birth that can be lived in the body rather than in the fear and I think some of us, we really have to learn that because we disconnected, and I think sophrology and dynamic relaxation really teaches that.
I'm quite frightened too. I think a lot of women are very frightened approaching pregnancy now. Richard, what do you think about that, about pain relief or managing with relaxation?
I think the most important thing with regards to relaxation is trust. And the way that I have worked, as it happens with you, for the last 8 or 9 years is because our patients know us from every clinic visit and speak to us during their pregnancy and see both of us in labour, they feel relaxed. And I think if you're relaxed by knowing who's looking after you and trusting who's looking after you, then your pain is more copable with, and you know that if you're advised at a particular point that perhaps one should consider this, that, or the other, I think that trust helps. So I believe that women should do what's good for them. And there are women that will go into labour thinking, I want to have an epidural, thank you very much. And there are women who go in saying, and often without full knowledge, I don't want any interference. But the sensible way of going into it is, let's see how it goes, and let's talk during it, and go where we go. Just one other point. When we're talking about the older ladies, just a very brief one, sorry to go back, we don't talk about older men. You know, if you get a woman pregnant at 55, good for you. But, you know, it's both parents. But my problem with women as they age, certainly women who are going to be looking after the children themselves, it's very difficult being a woman in your mid-50s, looking after a 10-year-old and taking a 10-year-old to school and getting up at night at 3 o'clock in the morning. It's much easier when you're 20 and 25, and it's all the other aspects postnatally of having a baby later in life.
You could balance that, though, with the fact that women that are older are generally more stable, they're more financially stable, and they're more willing to commit the time to it.
Yeah,
So I think there's arguments on both sides, really.
But some of our women having babies in their 40s are having number 8. So they may not be as financially able.
Well, that's not a usual. I'd say that's fewer rather than the majority. Armin, I just wanted to ask you, what alternatives to IVF are there? Any options for getting pregnant when you're older without actually resorting to IVF?
Well, it depends on the age and the ovarian reserve. If the woman is beyond 45, we had a patient who got pregnant at 46, and we have a couple of patients who got pregnant at 45 with IVF. At that age group, the alternative only is egg donation. It's still IVF egg donation. I can't see any other alternative.
So that's the only route they've got, really, from...
Well, either IVF on eggs or going for egg donation. Obviously, as you probably listened to my talk earlier on, if their lifestyle or their plans not to have kids until that age, when they are young, if they know, they better freeze some embryos if they are married or in a established relationship, or if they are still single, early or mid-30s, and they are not planning to have kids for the next 5 years, they can freeze eggs. And this is...
How common is that now?
It's getting better. Until a year ago, the youngest patient froze egg in our unit was 38, which is a bit disappointing because, you know, you miss the time when you have good quality eggs.
Yes.
But recently, last year, we have quite a few patients who came at the age of 30 and 33. Because the way they plan their life, they're not likely to have kids for the next 5 years. And rather than missing the boat completely, they freeze eggs, and it's like an insurance policy. You might never need to use them.
Yes.
But this is the case with any insurance policy.
It takes quite a lot of forward vision to think about doing that, doesn't it?
I mean, there is no guarantee that you have a baby out of them, but there is guarantee to have a baby in IVF later in life anyway.
Yes,
And I always say to them, I prefer that if you get on and have kids at young age, because it's very natural. And I always say, as a community, we should support them or give them enough support financially and socially to start the family as young as they are at the time. But as I said, you can't judge everybody's circumstances. They decide, at least they have the option and the choice. And if they don't use them, as the research showed, many of them, more than 60%, are happy to donate their eggs to research. And some are happy to donate it to other couples who are less fortunate. About 18% would discard them, and 8% do not know what to do with them. And actually, my daughter is married, and she's nearly 28, and I said, I won't see you pregnant before 30.
You did?
Yeah, and she said, well, I've got to do this, and my husband's got to do that, and we still have to build this and that. And I said, well, you can't do everything prior to having a family. I'd love you if you can run things parallel. So career-wise, husband-wise,
yeah,
house-wise, family-wise, they go together. If you struggle, just ask me.
Okay, thank you. Oh, glad I'm not your daughter. No pressure on there. I just wanted to ask Richard, why do you think it's important that couples have access to an integrated healthcare team?
I think there are so many people involved in a pregnancy, from fitness to be pregnant, the nutrition to nourish yourself and your child, the ability to exercise, the ability to relax. Some people just need the experience of a midwife, and a few people need the experience of an obstetrician because of the family history or something happening in the past or something developing in the pregnancy. And all of these people work together, and the days of the obstetrician sitting in a clinic and saying, you will do this, have gone. And there are so many people sitting in front of you with such an important part to play in everybody's pregnancy.
Yeah, I agree. I think it is a team approach, isn't it? And that includes everybody that is on here. We should all be working together for the woman at the centre of care.
Without forgetting the osteopath when things hurt.
Yeah.
Sorry.
And in preparation.
Being very nice to each other, aren't you? I'm just going to ask you one more question, and I'd like to get back to the girls, if I may. How often would you see a private patient over the course of pregnancy? How frequently are their appointments?
I don't think just if people are privately, you need to drag them back to see you if they're well. And I think you should see them as often as you would see a patient on the NHS, unless they have need. And one of the joys of going privately is if you're more concerned or you're more worried, you have the access to extra appointments. But if your pregnancy is going well, you're normal as everybody else is. You just have the facility, if you have concerns, to be seen more often than you would be in a stretched NHS.
So what
Okay,
is
thank you.
normal now?
I mean, I would normally see patients monthly till 28 weeks, then every 2 to 3 weeks till 38 weeks, and then weekly till 41 and possibly 42. But very few people, Alex, as you know, get to 42 weeks now, because when we were young, we didn't have scanning for accurate dating, and very few people go past 10 days now.
Yeah, but the NHS has reduced the number of antenatal visits.
Yeah.
Now, it's not as much as that.
And GPs no longer see patients in their surgery. There used to be a lot of NHS shared care with the midwife and the GP, and now the midwife is left and the GP doesn't get involved at all. So often there's very little medical input, which some may say isn't a bad thing.
Well, it is, if they're well, it's not a bad thing at all. I think it reduces intervention. I want to ask a completely different question. Angelique, what do you feel about peanut allergy? There's a lot of talk about whether women should or shouldn't eat peanuts in pregnancy. What is your view?
Again, it comes back down to individuality and the person as a whole, but there is a lot more allergies and people are reacting a lot more to food at the moment. I'd say that if you've never had an issue with peanuts in your family, if there's not a history of anything going on from that point, then you should be fine with eating peanuts.
So why do you think there are more allergies? What's going on?
There's a lot more inflammation in the body, first of all. We're eating a lot more food-like products. We're not eating nutrient-dense food anymore. We're eating so much sugar that actually just causes this inflammatory cascade in the body. We're almost afraid of good fats, like the omega-3s, which can actually reduce the inflammation. And we're causing a systemic inflammation in the body, and this is leading to more food allergies. And I see it a lot in clinic, and it's not just with peanuts, but I'm seeing a lot more people are reacting to a diverse food groups as well, you know, whether that be some people are even starting to react to beef and chicken, and there's just so much going on. So I'd say that the lifestyle that we're leading, the busyness, the stress, and this,
but mostly the diet,
and this onslaught of sugar and refined foods and taking away the healthy foods. Like I see it in food diaries as well, where people are saying, but I'm eating healthy foods, I'm eating this healthy bar and this product that's said that it's healthy on the tin, but it's actually not. It's just a food-like product that's void of any nutrients.
So we should get back to real food.
Get back to real food. And I know it's difficult in today's day and age because we're so busy, but it's about making small tweaks to the diet and looking at how we can create a consistency above perfection, so getting good food in the majority of the time, so that when you are rushed off your feet and you can't get something that's nutrient-dense, that it's not going to make that much of an impact.
Thank you. I just want to ask sort of Alex and Amin together, really, because I think you're both involved in this. Do you think diet has quite a big role in fertility and gynecology problems in older women? Do you think diet would make a big difference if women ate differently? Or do you think it's just an age process?
I think only obesity really plays a difference and reduces fertility. And obviously extreme underweight as well. So those are two extremes can lead to non-ovulatory cycles and delayed pregnancy as a result. I'm not aware that...
Well, as Alex said, either weight is the best to improve your chance of having even natural pregnancy. But on top of that, there is strong evidence accumulating over the last year that nutritional stuff can affect, particularly vitamin D. Nowadays, we know now that vitamin D deficiency is linked to immune system overreaction or hyperactive immune system and overactive
there's some
immune
really
system.
interesting work come out on that, hasn't there?
And overactive immune system can reduce your chance of the embryo's implanting and increase miscarriage. So there is a link, and I think a healthy diet in the proper sense is important. Yes. And we routinely check a patient now for vitamin D levels, which didn't happen 4 or 5 years ago.
Yeah, it's quite new, isn't it? Yeah.
It's not very new. We have been aware of this about 4 or 5 years now, so relatively new.
Relatively new.
Yeah.
Okay, for someone my age, it's relatively new. Okay, I just wanted to have one more question to one of the ladies from Bloom 58. What techniques do you think women can use to stay calm during birth? Who would like to answer that one?
Both poised to, but
okay.
No, go ahead.
Don't be shy.
So what technique, do you mean like an example, a practical example?
Yes.
Or do you think
what's
one
of the techniques that you...
So as Umbreen rightly said earlier, the breath is a big one.
Yes.
You know, learning how to use your breath, especially the exhale, is a really powerful tool. Being able to connect with the non-painful part of your body, because when you're giving birth, yes, there is pain, but there are also a lot of other areas in your body that are pain-free.
Why is the exhale so important?
Because exhaling, if you lengthen the time of the exhale compared to the inhale, this relaxes your body. And the more relaxed you are, the more your muscle can be relaxed, and the easier the labor can happen, basically.
Okay, thank you. That's quite an interesting... A lot of people don't appreciate the power of exhaling. I think
and
it's something we don't do.
And also the oxygenation level.
Yes.
You know, if you breathe properly, your whole brain and cells are better oxygenated, so your body can perform better as well.
Lovely. Thank you very much. Richard, I'll just ask you one more question, if I may. How can pregnant women tailor their private healthcare packages to suit what they need? Because all women want different things from private healthcare.
I think various obstetricians will and midwives who work independently, and midwives like Jenny who work with a caseload, have the ability to see people as one-offs. There are some people who will just wish antenatal care with a private obstetrician and then go into the NHS. There are women who do it the other way around, that are quite happy to see their midwives during the pregnancy, but want expertise during the labouring process. And there are people who wish and can afford all of it. So I think we need to be able to offer everything from a one-off visit to full care, be it with your case-loading midwife, your independent midwife, your obstetrician, or your team.
Jenny, I sort of want to ask you a similar sort of question, really. Is what difference do you think it makes for women, for someone that you're seeing on your caseload, to see you at every appointment?
Well, I've certainly done that for families up to 4 babies sometimes. It is, for the midwife, I would say a complete lifestyle. I mean, it is your life, because you don't know when the babies are coming, and people's expectations of you being there, of course, are very high. And I've loved it over the years, and I always think it's such a bonus. But I think it's about what many people have said, about the continuity, about the trust of the midwife, about the ability to work with the woman in the way she wants to work and achieve, many things. A lot of water birthing I do. And it's all that sort of package. And then really what happens after that, I think the women select you or don't select you, depending on, are you that sort of person that I would like to go through my pregnancy? And I think, as Richard says, there are many different people in the pregnancy world that are very valuable. So certainly I wouldn't be the person that you go and have a blood pressure, feel the baby, you are fine, off you go. I'm much more frilly than that. So the woman would say, oh, don't go to her, she's a bit frilly. And I do think that's how the grapevines, work. And, my mummy will say after the baby, oh, well, she was so lovely, and this is how she is. And that other mother will decide, that's maybe not quite what I want, or maybe it is. And then she'll send her along. And I think that's the biggest power of, practitioners in different ways throughout all of our lives, really.
Thank you very much.
Can I just ask a question?
Yes.
Do you offer epidural as an option to them from the beginning, or at some stage, or to some women, others?
So,
sorry, I've got 2 now.
I would sort of say, that's good, sir. I usually say, look at your utopia plan and go through various options of that, what they would like. And then I always say, of course, the little baby may decide differently, because it's often the baby that might, or it may be the endurance of the mother through, particularly the first time labour, and to keep the options open. So during the antenatal time, I will say exactly what an epidural is and how it may be beneficial, and how we're so lucky really now. I mean, when I trained, it wasn't offered to everyone. We used, if you needed pain relief, you had pethidine. So it's a massive breakthrough, because their head is very clear for their birth. So get your epidural and then get back online, connect your head to your uterus, and we'll try and get you a nice normal birth just the same, really. It's not a pass or fail, or, asking, the next door neighbour, oh, you had it, so I'm better than you. It's just a passage of time for the birthday. But actually your baby, the rest of its life, is a very long haul that's very important. And some people always fix on the last contraction, the baby's here, and some others say to me, and what do I do next? And you've really antenatally got to get them beyond that. Here's your baby, because your baby's going to be with you. I know some of I've got 4, and my big ones are still needing the mother, So it's a very long journey afterwards.
I'm sensing from you that you are quite pro analgesia in labour. Is that why you're asking the questions?
It gives total relief, really, epidural. A
yes.
successful epidural gives total relief. And not all mothers are suitable, really, to go through hard labour.
No, they're not. It's all about individual choice. Yeah. I think if you give women the information about having or not having an epidural, and tell them all about epidurals, and they've got all the right information, I think it comes down to personal choice. And for some women, I think psychologically it's very important not to have an epidural. For them, it's very important that they try and do it without one. And for other women, they'll want one the minute they get into the hospital.
But I get the impression sometimes that care providers are pressurizing women not to have an epidural.
Well, that shouldn't happen.
Yeah.
That should never happen.
I don't think that happens.
No.
I think women who say, I want my epidural, then you know that's their utopia plan. I want to come in and I want it. And obviously, if they're in labour, they will.
Yes. So, I mean, really what I wanted to come across is that epidural is there, and it doesn't necessarily mean that you are failing labour if you decide to have an epidural.
That's a terrible word to use in relation to labour, because becoming a mother is the end point of that dream. It's how you get there needs to be safe, and it needs to be something that you can think about and talk about, but it is not the aim. The labour is not the aim.
Yes.
The baby and motherhood is the aim.
Sarah, without stating the obvious, the clue is in the word. It's not called Yahoo or Wow, it's called labour. And labour is hard work. And sometimes for that hard work, you need decent pain relief. And some people need it, and some people don't.
And I'd just like to add, from our perspective, of course, we would love for a natural labour, but our concept is around trying to support the woman through any pregnancy, through any labour.
Absolutely.
And sometimes it is a cesarean section, sometimes it is an epidural. It is following their choice and making sure their body and their mind are as best prepared as possible. Yes. When we spoke earlier about diet in regards to fertility, it's another thing that sorry to go back again, but it is one of those things I'm quite passionate about, in having the body prepared for, particularly when it is IVF. Your body might not necessarily be physically prepared for it. So encouraging blood circulation around the pelvis and good drainage through the area and good motility is often quite a welcome approach to having something introduced.
Yeah, I think it's all about choice and information, really. I think it's about everything to do with diet, to do with fertility, to do with whether you have midwife care, whether you have obstetric care, the kind of pain relief that you choose. I think choose is a good word, and I think women should be empowered to make their own choices about what they want for their own birth. Anyone has anything to add to that?
May I ask a question to all of you? Thank you very much for taking part in this discussion today. But I guess wrapping up our event, which is the Private Pregnancy Show, and we've spoken a lot in the last few days about private care, but a lot of you would have experience through the NHS, and I just wondered what can filter through to the NHS to help mums to be, if anything at all. Would any of you have an opinion on that? And maybe what do the current government need to do to try and bring some of those aspects that are available in private healthcare into the NHS, to try and make it all more of a holistic, difficult approach?
We need continuity, and the NHS cannot afford continuity. Women are always complaining. They see a different doctor in the clinic, they see a different midwife in the surgery, and none of the people they've met during the pregnancy is likely to be the person who's looking after them in labour. And the person looking after them in labour may disappear after 3 hours for a break, or we finish the shift and someone else comes on. You know, they'll have several people looking after them in pregnancy, several in labour. And what I think makes a good labour is knowing the people around you and trusting the people around you. And the NHS cannot generally fulfil that without a huge amount of extra expenditure.
I completely agree. I think it's all down to cost, really. I mean, the NHS would love to provide continuity of care and the kind of structure that would give women that in pregnancy, but it's affording it.
But also, the NHS should play a role to inform people about their biological clock. So the GP has a role. Are you thinking about the family? People should know through their GP and leaflets as well that the ovaries will decline from 35 years onwards. So better plan your family early, if possible.
I also think that the NHS doesn't have the time to sit within the consultation with the clients. So when I'm working with someone, I have an hour or I have 45 minutes where I'm talking about what they're eating, what they can be eating, what they should be avoiding. And we just don't have that time with the NHS. And, you know, as a starting point, I think GPs should be talking about what is your diet. If someone is trying to fall pregnant or thinking about having a baby, you know, what are you currently eating? What can you do to better yourself, to get yourself strengthened, to have those reserves when you go through pregnancy? Because it's a 9-month project. At the end of the day, you know, it's 9 months of your body going through all these changes, using up a lot of energy, using up a lot of reserve, and taking in the right nutrients before, during, and after is really important.
But as someone who was an NHS consultant for 24 years, and when there were 3 of us and I was the high-risk obstetrician, I had 800 women booked under my care who were potentially high risk. I now have a private caseload of 60 to 80 patients, which is enough for me, and that's 10% of what I had to sometimes coordinate on the NHS.
So how can things improve? Because other countries in Europe seem to be able to do it better. I met an Italian girl today who said in the UK you need to have both private care and NHS. So how can we be more like France or Spain?
What do they do in Italy?
I didn't ask. But, you know, she did make a point. And, you know, I'm Irish and it's the same in Ireland.
I think the training grades in Europe often, I think that the period of training is shorter. And I think a lot of people stop at our equivalent of registrar and senior registrar levels and come out to do not a general practice but a more general obstetric and gynecological practice, and the super specialists continue their training for the length of time that we continued our training. So I think there are a lot more people who are dealing with general basic obstetrics and gynecology in the community in Europe, and far fewer people in the tertiary centres, whereas we've lumped everybody together in NHS hospitals and overtrained them. You know, we've trained our obstetricians and gynecologists to scan, to do gynecology, to do incontinence procedures, to deal with the menopause, and they've been much more specific in Europe, as we are now, in honing the training into certain areas.
Jenny?
I was just going to say, I mean, I actually think the NHS is very good. And I mean, I've done 30 plus years in the NHS, and I'm still employee of the NHS. And I think that there's, the mother has to lead the way, and all my philosophy of care is the mother's leading the way, and I'm following, trying to sort things out, and I've learnt so much from them. And I think it's a sort of shared philosophy of care, and if they do come in with their ideas about what to do in labour, certainly on mainstream labour wards, they put their own little lights down, they sit in the birth ball. Most people are going around that and facilitating. So I think have your bubble in your mind about what you want to do. And, my colleagues, for many years, I think there's amazing midwives, obstetricians.
Yes, I agree.
And I really think, there's a lot happening. I think the continuity, Rich, is absolutely right. And I do think that some models, interestingly, in the last paper, they didn't talk about continuity, which I was actually quite surprised with. It was about a paragraph from the latest report. So, and I think if you can't get continuity of the person, then the establishments need to ensure continuity of a philosophy of care with the mother at the centre. At all times, and I think, I must say, I don't think I think the private care is lovely and it's a luxury and we're working in it, but I think the NHS is equally as good in many different facets.
Yeah, I agree. Anybody else?
Well, I'd love to see the NHS offering fertility check for young women from age of 25, just a checkpoint to plan their life afterwards. That's number one. It would be great if they can offer more fertility services in terms of IVF, in a wider range. And I'd love to see the specialists and consultant NHS to think a little bit outside the box, because I'm not sure whether this is the way they do or is it the guidelines that they give the patient the same thing again and again, and they are not free like we are in the private sector. And maybe I just take the responsibility myself to give my patients further treatment in the form of immunology and infection and other things that would help many of them. And I can see patients coming from the NHS and they said, well, you might need some more, but we can't give it to you. So I'd like to give flexibility to the consultants, not everybody in the team, but the responsible consultants, experienced consultants, to work outside the box a little bit to help patients who have been repeatedly unsuccessful.
Thank you. Unless anyone else has anything to add, I think we'll finish up. Thank you very much, and thank you, Sarah, for moderating, and to all of you for staying around till the end of the day. Thank you. It's a pleasure to have you.
Thanks.